Hello everyone. Okay. Today we are going to be talking about antimicrobials. This is on Blackboard. This is the first part of the presentation. So let's just go ahead and get right into it. Hopefully you have learned, well, you don't have to for the test, but I would recommend you listen to the introductory video first. It just gives you kind of a little bit of overview and it gives some recommendations more for rotations. For testing purposes, that introductory video will not be testable. It's just, it's more FYI, it's more FYK for your knowledge. But here we go. This is going to be the meat and potatoes, as people say, for testing purposes and for my course. So this is just, again, kind of overview some things that will help when picking your antimicrobial therapy that ideally you'd like to minimize the adverse effects and the toxicities to the host, and you want as kind of a specifically kill the pathogenic microorganisms as you can. You're also concerned about adequate blood levels. So what does that mean? Adequately dosing. So I don't test overdosing. So you're not responsible for dosing for my exams, but that will be definitely something you see out in practice and on your rotations. And so what all that means is that you just need to make sure you're doing the appropriate dose, especially with pediatric patients. We will do some pharmacy math calculations later on in the year, and we'll talk about calculating the appropriate dose for pediatric patients, and that comes up a lot with antibiotics. A lot of them are weight-based. They also can be age-based. And then the other population you have to think about too is geriatric population, or if anyone has any comorbid conditions, or if they're immunocompromised, or if they have really weak kidneys or weak liver, etc. But basically, different factors that can come in to affect the blood levels, and you need to make sure you have adequate blood levels. Mechanism of action with this, so definitely testable material. I want to make sure you guys know mechanism of actions for medications. One caveat with that is if I don't list the mechanism of action, or if I don't spend a lot of time on it, don't worry about then going and trying to dig that up and find that out. Just stick to what I present you as far as mechanism of action. And then specifically for antimicrobial drugs, a lot of the mechanism of action are also how they are classified. And so the classification of drugs is important and will also be testable. So make sure that you're keeping your classes of medications in line, or rather make sure you're keeping those straight, and then also make sure that you are keeping your mechanism of action straight. So here is, oh man, that's kind of blurry too. Sorry about that. Here is a picture of where some of these antimicrobials are working. So you can see there's some involved in that disrupt the cell wall synthesis. Some affect folic acid metabolism. Some affect DNA over here. Some affect protein synthesis, etc. And so again, visual, don't necessarily feel like you have to be able to reproduce this slide, but definitely this is good, and pay attention to which drugs fall under which categories, and then also this will affect their mechanism of action. So for example, penicillins, cephalosporins, you need to be able to know that they will affect cell wall synthesis is part of their mechanism of action. So we just talked about in that slide before, there are a few different ways that you can kill a microorganism, and these are some of the ways that we have drugs that will do that for you. And here's the slide again. Not sure why I put it again. I have a big smile on my face, so sorry about that. Resistance is a big issue. I talked about this in the you'll notice too that I also have a lecture for pathophysiology. It's chapter 12. I put there as an FYI for my course. It will come into play and it will help be beneficial for pathophysiology. But anyway, so I've recorded that integrity already. Some students like to listen to the pathophysiology before pharmacology, but I talk about resistance there. I also talk about resistance a little bit in the introductory video. So I'm trying to be too repetitive, but definitely you need to be concerned about resistance. It's a worldwide issue, so it affects everybody. We're global citizens, right? As people sometimes like to say. No, but I mean, all joking aside, we are global, or I feel like we are global citizens, especially when it comes to microorganisms, because they don't respect political boundaries, right? They don't care if they're in Reynosa or McAllen or Matamoros or whatever. They're, and let alone Canada, China, etc. Right, and then with international travel being so easy, or relatively easy nowadays, with airplanes, etc., definitely a worldwide concern. So this is basically, the more you expose a microorganism to an antibiotic, the more likely that those microorganisms will adapt and evolve, so to speak, and then that will make the antibiotics no longer effective in killing them. So the frequency of antimicrobial use is a big issue with that. How often are these how often are these microbes exposed to these antibiotics, for example, can play a role. So that's definitely where you need to be as conservative as possible. And overprescription of antibiotics is a big concern. It's not just for PAs, and it's not just for physicians. Well, it's for anyone who can prescribe. But not just PAs. I'm not just picking on you guys. It's anyone who can prescribe. Definitely be mindful about prescribing antibiotics and antimicrobials, and make sure that you're using them when you have a true indication. And that'll be something you'll be learning more in ICM. I'm not going to pretend that I'm an expert on that. My wife makes fun of me sometimes because some of the stuff that I think is appropriate. She's a physician, by the way. So she definitely has a better idea of that. So you guys will get. I won't be testing you on that. I won't be expecting you guys to know. I won't go into that kind of nitty-gritty of that. Total quantity of the drug dispensed, that just means are you giving an appropriate dose for an appropriate amount of time, and then also too, is the person finishing the medication? So if they just take a little bit and they don't finish the antibiotic, one is that they they may be feeling better but they still are infected, and the other thing is too that can help with resistance, because it potentially leaves some of the bacteria, for example, there left, and the ones that are not fully killed by the antibiotics, for example. Location of the patient when receiving the medication. So it is, I said it's a global issue, but it's also geographic in the sense that it can vary. So resistance patterns will vary depending on where you practice, depending on what part of the state you end up practicing in, and then depending on what part of the country you end up practicing in. And then I know some people may end up going international too. So depending on what part of the world you end up practicing in. So I've mentioned that there are antibiograms. That was in my introduction video. So always take a look at those, and that'll give you a good idea of local resistance patterns. And then immune status of the patient. So are they immunocompromised, immunocompetent, etc. That's definitely going to play a role. And that has a lot of implications, but can help, or rather make resistance a bigger issue. This is just more of the same, so just read through these, but this is just basically saying the specific mechanisms of the microbial resistance, so I won't read those to you, but read through those, and this is basically the more specific way of where microorganisms can gain resistance. And here's a table too. Again, sorry for it being so blurry. This is just kind of an FYI table. Don't worry about memorizing these as far as what column they fit under, but just know that it basically, if it affects all these antibiotics here, and that there's just specific ways that it affects the antibiotics. But for my testing purposes for my course, don't stress about memorizing which ones fall into which category. Just be aware of the that resistance is an issue, and then some of those factors I talked about earlier. Multi-drug resistance is also an issue, so it's basically where you are infected with some kind of microorganism, so some bacteria. In popular culture, you may hear this referred to, or like on the news, for example, they refer to these super bugs, but it's basically where something is resistant to, let's say, first, second, third line, or first, second, third line of an antimicrobial regimen or prescriptions, and so where you have to go to bigger and stronger medications. And then here's some bullet points here that I think are good, and you guys can read through these, but it's just basically tips out when you are a practitioner to help hopefully minimize the emergence of resistance. So just again, some basic definitions, basic background. We talked a little bit about this in the pathophysiology lecture, but there are bactericidal agents, and then there's bacteriostatic agents. So under bactericidal, so these are the ones that it's like homicidal. The cidal means actually killing. So these bactericidal agents actually kill the microorganisms. And there's two subtypes under there. Concentration dependent killing, so meaning that you have to have a certain concentration before you're able to kill the microorganism. And then time dependent killing, and this is where resistance, that making sure that they're on the medication long enough. So time dependent killing means that the microorganism needs to be exposed to the antimicrobial for a long enough amount of time. So it could be 7 days, it could be so many hours, so basically when this certain microorganism is exposed to this antimicrobial for X amount of hours, then it's bactericidal. So then it kills. So anyway, so again, dose, or how high of a level you get. And inpatient, some of the inpatient antimicrobials, you guys will see where they'll be taking drug levels to make sure that maybe the concentration is high enough. And then here's some just examples underneath. Don't stress again about memorizing this for my testing purposes, but just use it more FYI. Aminoglycosides, fluoroquinolones, which we'll talk about, are concentration dependent, and then the beta-lactams and vancomycin are time dependent. And there's also bacteriostatic agents, so here's the list of bactericidal, again, bacteriostatic. Again, for my exam purposes, don't stress about memorizing these charts here. But then bacteriostatic, basically static is, you can think of it as like stasis. It means to stop. So the bacteriostatic agents, they actually stop the growth and multiplication. So they are not cidal, or they're not bactericidal. They don't actually kill the microorganisms. But they're beneficial in that they stop the proliferation of the bacteria, for example, and then it allows your immune system to come in and then fight it off. So you can kind of think of it as it's sort of halting the progression or halting the spread of a microorganism. There are indications, and you will definitely see this out in practice, where antibiotics are used prophylactically before. And so before you actually maybe need them, or before you have an infection. So just read through these again, FYI. Don't stress about memorizing them, but you will see this definitely. You will see this definitely on your rotations and out in practice. But so one that comes to mind for me is surgical procedures. You see that a lot. But then there's other ones too. Dental procedures. So you guys may have had this happen in outpatient setting. You have needed wisdom teeth pulled or something. I don't know. And I don't know what you guys are up to at the dentist now. So you have to do something at the dentist, and they'll give you 3 days of an antibiotic that you're supposed to take before. So it's prophylactic. It's the idea is supposed to prevent its use. Related to resistance, definitely be mindful and make sure you have a legitimate reason to prophylactically prescribe anti-infective agents, because again, resistance is there. So don't just be like, well, whoever is going to do anything medically or be in the hospital just needs prophylactic antibiotics, because that would just one, it can increase adverse effects and ill effects of the drugs to the patient. Two, there's the resistance is a big thing, and then third, cost, which it's hard to think about as a new practitioner, but it's definitely something that, it's part of the national stage right now as far as healthcare costs, et cetera, but it's definitely something you'll notice out in practice. There's a lot about the cost of healthcare and trying to wrangle in that cost. So another reason too. Adverse effects. So this is an overview of adverse effects. I'm going to go through specific ones with specific groups or specific antibiotics, but definitely be mindful if I note any organ-directed toxicity, make sure you know those and which drugs they're associated with. So ototoxicity is hearing or hearing loss related. Hematopoietic toxicity, so those are going to be blood disorders. Hepatotoxicity, that's going to be if it's toxic to the liver, and then renal toxicity is where it's toxic to the kidneys. So I kind of joked before about how pharmacists, we only care about the liver and kidneys, but definitely pay attention to if I list if a medication is hepatotoxic or renal toxic. And then there's idiosyncratic, which basically means something that's unexpected or quote-unquote unpredictable, but there sometimes are idiosyncratic adverse reactions, which I'll mention. So photosensitivity for tetracycline, for example, is one where it's something that may be unexpected, or it's just only to that medication or that one of its class. Or so I'll give those examples too. So note those if I note them. And then hypersensitivity reactions. Definitely something that you want to think about when you're prescribing medication. So that's one of those first things. I know there was one of y'all that had worked in a pharmacy, but it's one of those first things we asked in the pharmacy. And a lot of times in the doctor's office, hospital, they'll say, are you allergic to any medications? This is because unfortunately that there can be hypersensitivity reactions, and it's type 1, right? FYI, a little ICM help there. A type 1 hypersensitivity reaction, right? You guys are probably learning about that or are about to learn about that. But these, the kind of textbook ones, or the ones that you hear about a lot, are with penicillins. And then related to that are the cephalosporins, which we'll talk about a little bit later. But so if a person has a true type 1 hypersensitivity reaction to penicillin, there is a potential for them to also be allergic to cephalosporins. And so that's something to be taken into consideration. And please note that. And that's definitely something I want you guys to be able to recall. And then there's also a problem with the sulfonamide. So we'll talk about the sulfonamide antibiotics. And then related to the sulfonamides, there are some other medications that their chemical structure is close enough to them, or they basically have sulfonamide-like groups within their chemical structure. Remember organic chemistry, everybody? Everyone's favorite. Yeah, I hear the applauses from far away. Yeah, everyone's cheering. No, but don't worry. I'm not going to make you guys worry. I'm not make you guys worry about organic chemistry or stress out about that. I'll stop doing my evil laughter. But no, it's just something where I won't make you know the structure like we did in pharmacy school, but just know when something has cross sensitivity, I will mention those. So like one we'll talk about later is the loop diuretic. So furosemide is one of those medications that's chemically structured to the sulfonamide antibiotics. So if a person has a true documented sulfonamide allergic reaction, then you need to be careful about prescribing those. And this has historically been a bigger concern than it is now. So it's definitely still a concern, definitely something on your board exams, on my exam. Definitely it can be black and white as far as you need to be careful. Penicillins with cephalosporins, and then sulfonamides with the ones that are chemically structured. However, lately there's been more research done, and there's been more evidence to show that it's more of a theoretical issue and less of a real. So it's one of those rare but serious instances. But definitely as a new practitioner and for boards and for testing purposes, it exists. Okay, so for the record, it exists, but just know that you may see some physicians still prescribing. So definitely, I filled a cephalosporin for a person who has a documented penicillin allergy. And so it will it's rare, but it will sometimes happen, and it's just basically, if it's inpatient, you need to be monitoring the patient and make sure that they're not going to have an adverse reaction. They're not going to have a hypersensitive reaction. And then it may be something you don't want to do outpatient, or if the person's not under medical supervision. But anyway, so that's kind of the latest on those hypersensitivity reactions. But definitely board questions, etc. I've seen them, penicillins, and then you need to be thinking about cephalosporins. So anyways, superinfections. This is another thing that is related to the adverse effects of antimicrobials. Unfortunately, sometimes when you're trying to, do no harm and trying to help treat the patient, you can actually cause them some problems as far as adverse effects go. So, for example, you can unfortunately cause a. So sometimes if you wipe out, or rather disrupt the normal flora that a person has. So, for example, their GI, their gastrointestinal flora. Then you can actually cause an overgrowth of other microorganisms that are normally not a problem. So Clostridium difficile, which is right here, also abbreviated C. difficile, or C. diff, is, you may have heard that before, but C. diff is where a person's on antibiotics and it kills some of their healthy or their normal gut flora, and then it allows an overgrowth of Clostridium difficile, or they can catch C. diff in the hospital, or whatever. I mean, it's not always necessarily because of prescribing things, but it's just something that can happen. And then the same thing, fungal infection or this other staphylococcal infection, they sometimes can happen as adverse effects. But with the candidiasis, you want to use a antifungal, and then, so they're here listed here, nystatins, miconazole, fluconazole. And then C. diff, you're going to want to think about something that will go into the GI tract, and then it's also Clostridium difficile is an anaerobic bacteria, so you want to make sure that you have anaerobic coverage, or that you want to pick something that hits anaerobes. So you definitely, first line, you want to think about oral metronidazole, which is the generic for Flagyl. And then, by the way, too, I mentioned the brand name for testing purposes, generic or chemical name only, no brand names only. I may have brand names on there, but I'll have the chemical or generic name with them. But metronidazole, which is the generic for Flagyl, is going to be your first line, and then oral vancomycin. So they make IV vancomycin, but the oral, or PO, which is the abbreviation, the medical abbreviation for that, and is because it's not absorbed, and you want to actually get the vancomycin to the GI tract, versus if you give IV. Well, the other thing with IV too, there's issues too with toxicities, etc., and its dosing is kind of crazy. But anyways, so you want to give the PO vancomycin. And the same thing with staphylococcal enterocolitis. Synergism, this is just kind of an FYI, but you'll definitely see this out in practice, and the drug manufacturers make some combinations of this. But just know, don't necessarily have to memorize all the combinations here, but just know that sometimes giving more than one antibiotic can be synergistic, and synergism just basically means that they both help to kind of have a stronger outcome. And so the aminoglycosides plus penicillin is better than one or the other. And then this sulfamethoxazole plus trimethoprim, which is that they actually make that together. That's the generic for Bactrim, is something that's stronger because there's a synergistic effect with that. So just know that. And then potentiation. So potentiation is like synergism, and but it's defined as where two or more medications come together or are given together to have a response greater than the sum of individual responses to each agent. So basically, it's two is better than one. You can think about that. And so again, they make these commercially available. So this one you guys have probably come across here, the amoxicillin plus clavulanic acid. That is Augmentin, is the generic, but it's basically the two together are stronger than just by giving one. Antagonism. So there's just a couple of examples of sometimes there can be drug interactions you have to be concerned about with antimicrobials. So here's a couple of examples of those. So for the antagonism, potentiation, and synergism, again, don't necessarily worry about memorizing those. But one thing I noticed too. So this is actually beta-lactams and then amphotericin B. So amphotericin B is a drug name, and then this is supposed to be a beta. So if you guys could change, that's beta-lactams. All right. So here's just an overview table of what we covered. This may help you guys as far as forming your tables or when you guys are studying. I would look at this as definitely as far as the organ-directed toxicities. Make sure you know which ones cause which type of toxicity. So definitely put a star by that. Idiosyncratic responses, go ahead and look at those as well too. Put a star by that. Hypersensitive reactions, I wouldn't spend some more time on that, but put a star by that as well. And then the superinfections, I would pay attention to, look at those. I think those are also important. And some of this table may be repetitive, or you may see later on, but I like this table in general, and I'd like you guys to pay attention to that, please. So there's the big star for that, because it's a big blue star. I don't know why I picked blue, but this whole table, you just put a big giant star next to you. Any color you want, it's cool. I'm not gang affiliated. No, I don't care if you put blue or whatever. All right, so now we are going to get into the categorization. So definitely pay attention to how things are categorized. And so this is important for antimicrobials, but this is going to be for the whole course of pharmacology, or at least as long as I work here, right? I don't know. I mean, too soon? Is that too soon? Yeah. So I mean, they got someone new, so I don't know. I'm feeling the pressure here. Am I getting politely asked to leave, or what's going on here? But anyway, so as long as I'm involved in the course, I should say. I used to be, last 2 years, I'd just be like, hey, for the whole pharmacology, this is what we're doing, but anyway, so who knows? I hopefully will have a job and be with you guys this semester, next semester, and for Pharmacy 3. So fingers crossed. I'm crossing my fingers. Y'all can't see that. But so for as long as I'm involved in this course, for my course, for pharmacology, classification is very important. Part of that is because you're going to see those classification terms on your board exams, and then it's also going to come into play when you talk to other healthcare practitioners, when you're choosing prescriptions, when you read literature about new drugs coming out, etc. It's a big part of pharmacology. So, sometimes it's more important than others, and I'll kind of try to highlight that. But anyways, so yeah, the organization. Oh, what I was going to say is sometimes it's a little more detailed than others. So definitely with cephalosporins, I do want you to know which ones are first generation, which ones are second generation, third, fourth, etc. So that, so know which ones are cephalosporins, but then also the breakdown there. Penicillins, other beta-lactams, and then other cell wall synthesis inhibitors. And so all of these you noticed you can categorize depending on if you're doing a concept map, or if you're doing tables, or how you're organizing your notes, or if you're just doing an outline or whatever. You can go and put all of these under cell wall synthesis inhibitors, but then also make sure you know where they fit under that broad category. So just real quick little, I guess, typo, whatever. When I convert from using an Apple to Mac, this doesn't go through, but these are beta-lactam, by the way. They're not B-lactam. So make sure you change that to that. But just an overview real quick that cell wall synthesis is very important for life, bacterial life included. And then so these basically disrupt that is why they're effective at killing bacteria. So here we have a lot of things you maybe saw in biology, or if you took biochem. Don't stress out about this slide. From testing purposes for me, I will not make you be able to, I don't expect you guys to be able to reproduce this whole thing, or I don't know for you guys, but undergrad bio, we always had to redraw all these things, and so still have nightmares about that. No, but I won't make you guys redraw this or anything. But this is just showing here, so beta-lactam antibiotics and vancomycin, and this is the step here that they're affecting here. It's the sixth step in here, so it's a cross-linking of strands by transpeptidation, and this is inhibited by this is to be beta-lactams. So again, don't stress about this slide too much. Again, FYI, don't want you guys to have nightmares about organic chemistry or anything, but this one, again, just look at them. This is just showing the structure and that they have this beta-lactam structure in it that's consistent throughout all of them, and this is basically where they got their name. But this is just FYI for my class. Don't worry about that. So here are some overviews about the penicillin. Specifically, we have penicillin G here. And so beta-lactam ring, just FYI, the penicillinase sensitivity, just know that depending on if this is an enzyme that can actually it chops up the penicillin, and so penicillin can be will not be effective if the microorganisms have the penicillinase. So that's kind of FYI too from my course. Acid liable, just they don't do well in acidic environments, just FYI. Tubular secretion, same thing. Inhibition of cell wall synthesis, definitely pay attention to that, put a star by that. I want to make sure you guys know that's part of its mechanism of action. And then the hypersensitivity, put a star by that, because that's another important characteristic of penicillins. The pharmacokinetics, so I talked about earlier that they're acid liable, so they don't survive in acid. So they make things, or they make products specifically to deal with that. So they have acid resistant preparations, but other than that, for PO administration. But other than that, don't worry about memorizing that. Just know that they are specifically formulated to get past the gastric exit of the stomach. Distribution. This is just, again, kind of FYI. This may come into play later, depending on it. So if you're trying to give a penicillin and to hit the prostate, it's poor penetration. So not a good idea to get that, to prescribe that. And the eyes is the other way. So this is another instance too where I would want you guys, if you're out on rotations, to refer back to the Sanford guide, because the Sanford guide has a section where they talk about prostate, and then if you have a prostate infection, what are first line, second line, etc. And then the CNS, central nervous system, with the exception of meningitis. Excretion, this one just is FYI, don't worry about it, other than there is the potential for a drug interaction. So with probenecid, we'll see later in the GU module, I think. So it's used for or maybe not. I don't know. I forgot which modules in. Don't quote me on that. But probenecid basically is a gout medication that's used sometimes, and so there's interaction with antibiotics. And just in general too, I get a lot of questions in the pharmacy, or people want to know about their antibiotics with drug interactions. That is something you have to be thinking about just in general terms with antibiotics or antimicrobials. The good news is most patients don't need to be on antimicrobials for long amounts of time. So a lot of times in the pharmacy, so let's say they're on probenecid and then they need to be prescribed a penicillin. A lot of times it's just something to mitigate. You just will just DC the probenecid maybe for the 7 days they're on the penicillin, for example. Again, it's going to depend on the patient and everything, but a lot of times with these drug interactions with antimicrobials, usually they're not on the antimicrobials for a really long time, so not super hard to manage. Mechanism of action we talked about already. Definitely make sure you pay attention to that. But it's basically it's basically a cell wall synthesis inhibitor. So take home point for that. And then the next 2 bullet points, it binds to these specific PBPs. So that's just FYI. And then bactericidal, just FYI for my course. Causes of resistance, again, FYI, but these are just some ways that this can happen with penicillins. But anyways, you can just read through those, and this is where this slide too will also be FYI for me. So uses, just real quick, this isn't going to be an end-all be-all presentation as far as uses. There's just too many uses for these antimicrobials and not enough time, and as it is, this presentation is super giant, but the ones I highlight, definitely make sure you know those and pay attention to those. So we have here penicillin G, some different uses here, pharyngitis, syphilis, pneumonia, meningitis. This is a intramuscular IM form of penicillin G. So this one you may see some depending on where you're, but so for example, for syphilis, they can do an IM injection of that. Or the beta, this is again beta-hemolytic streptococcal pharyngitis prophylactics. Maybe, again, you have to be mindful of the prophylactics, but you may see that too out in practice. Ampicillin and amoxicillin, they have extended spectrum. So if you remember from my introduction lecture, gram-positive, gram-negative, aerobic, anaerobic, that's the spectrum or potential spectrum of an antibiotic. So with a narrow spectrum, it just maybe only hits gram-negative, where the more you increase the spectrum, the more types of bacteria it hits. So a broad spectrum or a more broad spectrum antibiotic wouldn't just hit just gram-negative, it would hit gram-negative, gram-positive, and so this is relatively speaking, these have a broader or extended spectrum of penicillins, which you guys have probably seen. They're prescribed pretty regularly. So here's an example here of ampicillin given with sulbactam. That's an example of the potentiation we talked about earlier. It was on a previous slide. This is commercially available as Unison, and this is one that has a very broad spectrum, especially when given in combination. Because again, remember the potentiation means that they're stronger when they're given together. So the Unison, the ampicillin plus sulbactam. So you'll see the Unison. It's not always first line. It's going to kind of depend on what hospital you work at, but it's used for a lot of different skin infections, intra-abdominal infections, some gynecological infections. But the spectrum is that of ampicillin plus organisms producing beta-lactamases. So, for example, Staph aureus, H. influenzae, E. coli, Klebsiella, Enterobacter, and it also has anaerobic coverage. And then amoxicillin is given the clavulanic acid I mentioned earlier, previous slide. That's augmentin, so you see that being probably prescribed a lot. And then uses for ampicillin and amoxicillin, just in a nutshell here. So I'd mentioned that it hits E. coli, so maybe UTI, infectious diarrhea, otitis media, so ear infections, meningitis maybe caused by listeria, maybe prophylactically for endocarditis, and then bacteremia when it's combined with aminoglycoside. And I'm using kind of wishy-washy language just because, again, it's always if the bacteria is susceptible to the antibiotic. Piperacillin. So this is an anti-pseudomonal penicillin. So I definitely want you guys to remember if anything that hits Pseudomonas. So if it's anti-pseudomonal, definitely pay attention to that. But this one, Piperacillin can help treat Pseudomonas infections. It's typically prescribed to aminoglycoside, also given in combination with a clavulanic acid. So they actually have it commercially available. There's Piperacillin plus clavulanic acid. It's the old brand name was Timentin, but it's no longer. It's just generic now. But it's comes together. It's like Augmentin. They make the Piperacillin with a clavulanic acid. And just a quick note too about the clavulanic acid. Make sure don't get tongue-tied on that. It's also given the amoxicillin. So it inhibits the beta lactamases, and the beta lactamases will they'll inactivate, or they're enzymes that will chop up the amoxicillin or the Piperacillin. So the clavulanic acid is given in combination, so it's synergistic. It's given in combination with those medications, again, because it inhibits the beta lactamases. Whereas the Piperacillin then inhibits bacterial cell wall synthesis. So again, for organization purposes, make sure you keep that straight. Sometimes students in the past have gotten that kind of mixed up. But the Piperacillin and then the amoxicillin, ampicillin, they're bacterial cell wall inhibitors, and then the clavulanic acid actually inhibits the beta lactamases, which is an enzyme that deactivates the ampicillin. Well, it deactivates any of the penicillins. So this is another anti-pseudomonal penicillin, so definitely make sure you keep that in mind. Piperacillin. It actually is more effective than Piperacillin. Often given tazobactam, so this is another one too where they manufacture this in combination. So the combination is the Zosyn. So Zosyn is the brand name. So another reason I mentioned that, again, not for testing purposes, but just want to make sure that you guys are familiar with if you hear the name Zosyn, because a lot of times out in the hospital inpatient settings, they'll just refer to it as a brand name because it's easier to say than Piperacillin and tazobactam. Zosyn's got a nice little ring to it. Sounds flashy, right? Sounds cool. Also note that the Piperacillin again inhibits cell wall synthesis, but then the tazobactam it's like the clavulanic acid. You'll remember from there. The tazobactam is a beta lactamase inhibitor. So again, the beta lactamase would normally kind of gobble up or eat up the Piperacillin. So giving them in combination allows more of the Piperacillin to be able to kill the bacteria. So here, another typo, I'm sorry about that, but go ahead and change this 13. It's supposed to be a beta lactam antibiotic. Again, switching from Apple to PC, unfortunately, these things happen, and I keep meaning to change it. So I'm sorry, I'm going to change it. Penicillinase resistant beta lactam antibiotics. So this is for if there is a microorganism that produces penicillinase, which is an enzyme that deactivates and chops up penicillin. Then these could be beneficial. So nafcillin, oxacillin, and dicloxacillin. And then here are a couple different things. So you may see these being used with endocarditis or osteomyelitis. Adverse effects. So the allergic reactions we already talked about. So as a class, so for all the penicillins, you need to be concerned about that hypersensitivity, allergic reaction, definitely if it's documented. So it can happen in a person that it's not documented in, but it's definitely something if, it's documented. And then a quick note too about allergies. You want to make sure that it's a true allergy. It's a true type 1 hypersensitivity. That's just an FYI. But and then the other one for classes you have to be worried about, not common, but you can have seizures with higher levels. So that's something to think about. And it's more of those rare but serious. Unless, again, someone has a seizure disorder, then that's something you want to be more careful with if someone already is prone to seizures or if they have a seizure disorder. Okay, changing gears a little bit here, but not too far off. We have the cephalosporins. Cephalothin, just a little history lesson. Any history majors? No. Well, that's the prototype first generation cephalosporin is no longer available in the United States, and that's kind of what everything was based off of. So that's just FYI, don't worry about that. Here's some characteristics. So again, beta lactam ring, They are more resistant to the penicillinases, which is good. Mechanism of action, again, take-home message, they basically inhibit cell wall synthesis, so put a star by there. Acid resistance, more FYI, but so you have some PO agents, some oral agents. Nephrotoxic, so that's something to put an arrow by that, put a star by that. You want to be mindful of that when you're prescribing these, with the exception of ceftriaxone, which is the generic you may have heard of, is Rocephin. So you may have seen that the Rocephin IM, they have intramuscular injections of that. They sometimes give some clinics are known for giving those. No, but you may have seen that. Mechanism of action, like I said, it's similar to penicillin. It is bactericidal, FYI. And take-home point for mechanism of action, inhibition of cell wall synthesis. I mentioned too, the penicillinase doesn't hit it as much. And then also too, you have to be concerned about the hypersensitivity. So there's a cross hypersensitivity with, so if a person has a true documented penicillin allergy, you may have to be concerned about giving them cephalosporins. So again, for board purposes, testing purposes, remember that, please. Uses, I go ahead and break them down here is based on their generation, just to make generalizations of them. So again, important that you know which ones are first generation, second generation, etc. to definitely memorize those categories. First generation, we have a list here. Read through that. And parenteral, by the way, that just means IV, so it's not versus oral. So in general here, good activity against gram-positive bacteria, and then modest against gram-negative. So that's something to think about when you're prescribing. And then here's some uses that you may see these being prescribed for. Second generation, this has increased activity against gram-negative, so it's widening the spectrum. So gram-positive, then plus some more gram-negative. And then here's some uses there that you may be seeing those for. And the other thing too, just so you know, for the rest of pharmacology, we will be revisiting these anti-infectives. So we're going to have these in every module. So when we talk about an H. influenzae later on, maybe referring back to these second generation cephalosporins, for example. Third generation, again, pretty long list. We talked about ceftriaxone a little bit earlier. But then these actually have less activity against gram-positive, but then they have even more activity against gram-negative. So first generation, more gram-positive, less gram-negative. Second generation, increased gram-negative, still have the gram-positive. And then the third generation, decreased gram-positive, and then increased gram-negative. So hopefully that helps. And then we have a couple here that are pseudomonas, that could hit pseudomonas. So definitely put a star by those, remember those. And then we have some more specific uses here, which you may or may not seen just out in practice or whatever. Fourth generation here, we have cefepime. And this is a very broad spectrum with gram-positive and gram-negative activity. And this is used usually last line. Again, because of resistance, it is something that you should maybe not jump to first and use when you really need to. So kind of nice here, just for fourth generation, you just have the one that you need to remember. One slide that you should add here, and apologies for not having it in here for you guys, but there is one fifth generation cephalosporin. So it's ceftaroline is the generic name, and the brand name is Teflaro. So definitely add those and write that down. And it's spelled CEFTAROLINE is the generic, and then the brand name, or the chemical name, and then the brand name is TEFLARO, Teflaro. So this one is actually has similar activity as ceftriaxone, but with more gram-positive coverage or more gram-positive activity. Specifically, it could be beneficial with an oxacillin-resistant staphylococci. It also has higher activity against MRSA, and it can also help with vancomycin intermediate Staphylococcus aureus, the VISA. Okay, so there it's written there. I forgot that I'm recording this at home, and I can just pause it and then type up the slide real quick. But so the one fifth generation you have to worry about is Teflaro is a brand name, and then it's ceftaroline. So definitely note that. And then everything I said, please write that on this slide. I would appreciate that. And as far as its uses, you may see it for, or it's FDA approved for community-acquired pneumonia and then some skin and skin structure infections. But probably again, because it's a bigger, broader spectrum antibiotic, probably should limit its use and not try to get overprescribe it. Adverse effects. I mentioned earlier that the nephrotoxicity is something you'd be concerned about, with the exception of ceftriaxone, so definitely put a star there. It is dose dependent, and then also depends on the patient, etc. And then it's something that you need to be concerned about when you're using other medications that are nephrotoxic or have nephrotoxicity. So, for example, amphotericin B and the aminoglycosides, which we'll talk about later. The other thing we talked about too, the drug hypersensitivity as a class. Note that if they have the penicillin allergy, that you still need to be concerned about cephalosporins for hypersensitivity reaction, and then the disulfiram-like effect with alcohol. This is just basically means that they'll have a really severe, painful, flushing, stomach pain, etc. reaction if they have these medications, specifically some of the second and third generation cephalosporins, and if they take those with alcohol. And disulfiram is a medication. This is the generic antibuse, so it's developed to deter people from drinking alcohol. So you basically have a violent physical reaction when you take antibuse, which is disulfiram. So these cephalosporins give you that disulfiram-like effect when you ingest alcohol. And I definitely in the pharmacy always have the little ladies that are appalled that I assume when I tell them this, and I'm assuming that they're drunks or something. So this is any alcohol. So some cough syrups have alcohol, or some mouthwashes have alcohol. So just notify your patient, or just think about that, and educate your patients accordingly. And then hopefully in the pharmacy too, we'll catch them and let them know that they shouldn't be taking this with alcohol. But yeah, classic little ladies like, oh, I do declare, like, there's no way I would, I don't drink alcohol, whatever, but it's like, hey, it could be in your cough syrup, could be in something else, or some desserts will have alcohol or made with alcohol. So anyways, as far as a class is concerned, definitely note these for the cephalosporins. So for now, I'm going to go ahead and stop here. I'm trying not to make these videos super, super long, so I'm going to break these lectures up so a little bit more manageable, and they're not super giant presentations for you all. So for here, we'll go ahead and stop here at other beta-lactam drugs. And then we'll pick that up in part 2 of the recording. All right. Thank you guys. Talk to you later. Bye.